All right, so next we'll have Dr. Angela Zhang and Dr. Erica Cahill speaking on vaginitis and vulvar disorders. Dr. Zhang is a clinical assistant professor of medicine in the Department of Primary Care and Population Health. She's the medical director of Stanford Family Medicine, as well as the director of the O'Connor Stanford Leaders in Education Residency Program. She received this year's Department of Medicine Teaching Award at Stanford School of Medicine. Dr. Erica Cahill is a board-certified gynecologist with interest in reproductive and sexual healthcare education. She's the director of the Complex Family Planning Section in Gynecology and the Ryan Program Director for the Stanford OBGYN residency. She has numerous publications, has given many talks on abortion, how trauma affects reproductive health, and contraceptive care, to name a few. Thank you both for working on this lecture today.
Our talk today is titled Discharge and Itching and Lumps, Oh My. We'll be talking about vaginitis and vulvar disorders. And we have no disclosures. We'll start with our first case. We have a 26-year-old patient with vaginal discharge and burning. So this patient is presenting with 5 days of itching and burning, and they have no sexual partners and has been self-treating with monostat, but it has not brought any relief. On exam, you note that the patient has thin gray discharge, but no cervical motion tenderness. And on a wet mount, you note clue cells, and the vaginal pH is 7. So when thinking about the differential of vaginitis, I like to think of it in 2 broad categories: infectious or non-infectious causes. For infectious, you have your BV as well as Candida. This particular patient with the clue cells most likely has BV. There's also a variety of sexually transmitted infections as well that you would want to rule out if the patient's history suggests that. For your non-infectious causes, because the area is skin, you can think about anything that can happen elsewhere on the body. On skin can also happen in this area as well. So contact dermatitis, as well as locally lichen, the lichens, and then vulval vaginal atrophy you may see in a younger patient who's on long-term OCPs, or if they are receiving gender-affirming care with testosterone, you may also see vulval vaginal atrophy as well. So with this patient, we diagnosed bacterial vaginosis and treated with, you can treat with 2 different options, either locally with metronidazole gel for 5 days, or PO flagyl for 500 milligrams twice daily for 7 days. 2 weeks later, the patient returns, and unfortunately, their symptoms did improve for a few days, but now they've come back. And with further history, the patient notes that they've had 3 episodes of BV over the last 6 months. So my question for Dr. Cahill is, does this count as recurrent BV?
Thank you. So I think really important to think about whether or not the patient was having symptoms. And this is so important because sometimes people will come in thinking they have recurrent BV because they've had bacterial vaginosis suggested on pap smear testing, or they won't realize that they've had recurrent BV because they were symptomatic and did have some sort of testing, but it wasn't documented. So reminder that you don't need to treat asymptomatic bacterial vaginosis. We don't really think of it as an infection as much as a shift in the bacteria in the vagina. That's true of a non-pregnant patient. That's a little bit different in pregnancy. And then just a reminder that that's bacterial vaginosis on a pap smear. You don't have to treat in the absence of symptoms. This is also important for reminding yourself to document whether or not someone has symptoms in your notes. So when you see bacterial vaginosis suggested on a pap smear, when you go back to send those results, you can either know for certain that you would have put symptoms if they had symptoms, that you're always asking that, or putting just in your note, no symptoms as you collect the pap smear. So how we define recurrent bacterial vaginosis is 3 or more episodes in 1 year that have positive cultures or gram stain, so sort of culture or gram stain proven episodes, and that are symptomatic. All of these things have to be true to really meet this definition, and it's important because we go down a really different pathway once we tell people and once we diagnose people with recurrent bacterial vaginosis than if they are having different types of vaginitis that are not necessarily caused by this shift. So why does recurrent BV occur? There's a couple of reasons, and I think that's important as we think about the definition of recurrent BV. So one is insufficient treatment. Either the antibiotics were the bacteria in that person's vagina was resistant to that specific antibiotic. The patient self-discontinued the medication before those 5 or 7 days. And then the presence of biofilms is something that's been being explored more and more in research, but this idea that some bacteria in the vagina and some people seem to be more, seem to form biofilms more than other people, which makes it harder for bacteria, the antibiotics to get to the bacteria. And then like anything, there could be a reinfection or a re-exposure, and we'll talk a little bit about some risk factors for that.
Thank you. That's very helpful. Frequently, I do have patients who ask about that BV on their PAP, so it's helpful to know to note that in the history when we're taking the history during the PAP smear. My next question is if we should empirically treat this patient or if I should culture them first.
Yeah, this is always a tricky question. I feel like the right answer is culture, just because it really helps us build the case for recurrent BV or dispel the case for recurrent BV. That said, we've all gotten messages from patients who are traveling or somewhere else and can't come in. And so I don't think it's necessarily wrong to empirically treat, but certainly someone who you feel like is going down the path of recurrent BV, I would really try to get some documented cultures or gram stains so that they can help guide treatment in the future. Other things with recurrent BV are to really document the treatments attempted and the response, the duration of symptoms, as well as different types of exposures. All of those can be really helpful in figuring out next steps in treatment. This is an example from one paper that I just think is very graphically interesting and also shows it in just like this really nice colorful way. So this sort of rainbow side is patients when they were symptomatic, and each color represents a different type of bacteria in the vagina. And then in remission, you can see there's a predominance of this green lactobacillus. The light green is a lactobacillus, and the dark green is actually a different type of bacillus. And you can see that not everyone has like no other bacteria, and some people have quite a bit of other bacteria, but that there tends to be this kind of shift towards that type of lactobacillus. This is just one example of how the tracking cultures of any individual person can be really helpful in noting when treatment seems to work or not, as when it's associated with symptoms. So you can see like no one sample could really guide treatment. There's a lot of individualness about the different cultures.
Thank you. What about how do I treat then once we've diagnosed that this patient does have recurrent BV? How would I treat them?
Yeah, so if you've made that diagnosis of recurrent BV, the things that we think about in terms of principles are, is there an option that this patient hasn't tried yet of kind of the key options for treatment for BV that I'll review in a moment? And if they've tried everything, what had the best response in the past? Could we try that again? Could we try that for longer? And then review the culture sensitivities because you've definitely gotten cultures now. So the mainstay treatment, the typical treatment for recurrent bacterial vaginosis is an induction followed by a maintenance, typically of metronidazole. There are other antibiotics that have been used as well, but the most common is metronidazole. And the induction is that same kind of 1 week of either oral or intravaginal. And then the maintenance is a intravaginal metrogel for twice weekly for 4 to 6 months. So really trying to like keep the shift down. And then often we will also use boric acid starting during the maintenance phase. Here we have to have it compounded by a pharmacy. And it's really important to know that it must be placed in the vagina, cannot be placed in the mouth, is really toxic. And you place it nightly for 30 days. So it's like the boost during the start of the maintenance phase. And then thinking about how we assess treatment effects. So ask the patient, remember, we're treating symptoms, not any specific bacteria. If you can remember that beautiful rainbow chart of all the bacteria, like it's a shift. There's no specific one bacteria that we're trying to get rid of. And then you can do a wet prep a few days after finishing boric acid to sort of show that it's cleared if you would like to, but the most important thing is symptoms.
And one follow-up I have is, do you ever find patients who typically treat with, let's say, vaginal metronidazole, will they switch to PO for the recurrent episode back, like to try one just a different way, or there's not really any evidence that one way is superior than that?
There is not any evidence for the initial induction treatment that one is superior to the other. I find a lot of it has to do with patient preference. Like there are some patients that don't want the oral side effects, which is like the disulfiram effect with mixing with alcohol or the GI side effects. And then there are some people that if they can avoid placing things into the vagina, they'll do that. So I think it's really a patient route of administration preference.
I guess, yes, the best one is the one that they will take.
So they'll take, right? That's right.
And was there anything we can do to prevent future episodes?
Yeah, so this is a big question. I think like a lot of different exposures that are not quite infections, but any sort of irritations, thinking about what was the irritating exposure, what was the thing that caused the shift. So these are common questions that I'll ask really anyone who has vaginitis, but especially in any recurrent episodes. So any new sexual contacts or practices. There are studies showing that there's a higher risk of BV with partners who both have vaginas. Sexual devices can pass bacterial vaginosis, new condoms, spermicide, even like specific partners seem to cause that shift more than others. Any new vulvovaginal practices or exposures, so like new soap, certainly if they started placing anything inside the vagina, new hair removal techniques or external things. And then always remembering to ask about any associated symptoms. This is probably less true of bacterial vaginosis, but it can be. It's important to know if there's any decreased estrogen state, like menopause, so having hot flashes or painful intercourse, something that would suggest maybe there's some atrophy or other things going on beneath the surface. So really assessing and reducing any exposures or irritants. And then this is kind of my vulvar hygiene public service announcement that I tell everyone. So really thinking about the vagina as a self-cleaning, self-rebalancing space, and really allowing it to do that in the best possible way. So avoiding tight clothing, making sure they're just rinsing with water, not any harsh soaps, using a mild soap externally. There are people that really benefit from external trying of like an oil or petroleum-based compress, like Aquaphor or things like that. Cool tea bags, so that where you actually like wet the tea bag, but place it on the vulva, not in the vagina, but externally. Using lubricants with sexual activity, avoiding KY, which is really the like most sort of chemical and also water-based lubricant that really dries up, but it's the one everyone knows about. So everyone starts using that and kind of sticks with that for life unless they are opened up to new options or told about new options. So there's many different types of lubricants. Avoid sitting in a damp bathing suit as much as possible, leaving the vulva uncovered. So like especially at night. Urinating immediately after sexual activity to really push bacteria out of the urethra and that whole area. And then in people, especially who get these bacterial vaginosis or other types of vaginitis around menses, asking about menstrual products and seeing if they can reduce the irritation that comes with pads or cups or discs or whatever seems to be the thing that they're using for menses, to see if there's something to shift there.
In terms of the menstrual products, do you see if they're one like period underwear or pads or tampons, or what tends to be less irritating?
Yeah. I think the most irritating is the big pads, but in my experience, the people who are using the big pads are not as interested in using anything else. Like they just are not interested in using anything internally. I think that like absorbent underwear has been a big shift for a lot of people, though there's a recent study that just came out looking at the amount of blood each of those things can hold. And the menstrual underwear holds like 1 ounce or something crazy. So it's like very, 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 very small amounts. So I think, can't be used in someone who has heavier periods. But yeah, I think the pads seem to be the most irritating externally for people.
Thank you. It's helpful.
But kind of same thing, like I don't think people are really taking our advice on what to use about those. They're going to use the one that works best for them.
So my patient wants to actually avoid antibiotics. Are there other options in preventing their BV or recurrent BV?
Yeah, sorry, we skipped. So probiotics are something that we get asked a lot about, it, and actually has been quite studied. So this is an RCT published in the New England Journal. This is a Cochrane database review, and then another study looking at probiotics as treatment for bacterial vaginosis. So really thinking about it not just as preventative, but as an actual treatment. And really the big takeaways there are that it actually may help, particularly when it's used concurrently with oral metronidazole. There is insufficient evidence, though, in looking through all the studies to recommend a route of oral versus vaginal. Unclear if you should time it with the antibiotic or after to kind of prevent recurrence. And then almost all the probiotics that have been studied are specific strains of lactobacillus, but it's not clear which strains. And going back to that kind of color chart, you can see like everyone has a different vaginal microbiome, and so it's hard to know exactly how to shift it, and it is possible that you just shift it incorrectly again. So hard to know. My big takeaway is like no clear evidence of prevention, but probably not harmful, and it's certainly worth trying in someone who has not responded to other treatments or has had a recurrence on other treatments.
And when might I refer to gynecology?
Yeah, so really anytime. This is my picture I show in all my med student talks too, but certainly recurrent BV, especially as we're getting into more cultures or more frequent vaginal exams. Your office may not be set up for that, and we really are. I know we didn't talk as much about yeast, but any non-candida species of yeast kind of sometimes can go on a deeper dive of things. Severe symptoms, and then anyone with any medical comorbidities, though you all would be much more prepared and able to manage those medical comorbidities, having to think about them in terms of the vagina. But really, anytime, we're here for you.
Thank you. So moving on to our next case, we have a 67-year-old patient with vaginal dryness. They have some pain with intercourse. They have a new partner and have recently resumed intercourse 2 months ago after over a 5-year hiatus. And their menopause was at age 52. And they've tried KY jelly, but it hasn't provided relief. Although now I've learned from your previous talk that we probably could try a different lubricant. On exam, this patient has decreased vulvovaginal secretions and loss of vaginal rugae and tissue fragility as well. And their STI screen was negative. So I treated the patient initially with Replens for 4 weeks, but unfortunately they still continue to be symptomatic. So we've now decided to move on toward an estrogen, but how do I decide what kind of estrogen to recommend?
Sure. So I think it's always important to remember to use the estrogen that is treating the type of symptoms. So if they're only having vaginal symptoms, you only need a vaginal estrogen. If they're having systemic symptoms of a low estrogen state, you really need a systemic estrogen. So vaginal symptoms would mean only vaginal dryness, irritation, dyspareunia, that's more of the symptoms described in this case. The options for vaginal estrogen are, we can talk about dosing in upcoming slides, but there's basically a cream, a ring, and then a pill that you place per vagina. The cream comes with this large plunger applicator, and I always tell people to throw away the applicator, and that's because you end up pushing, if you do the dosing with the applicator, people end up pushing like a huge chunk of cream up into the top of the vagina, and much of it comes out. It can't be absorbed completely because it's sort of too big of a chunk. The same way that you wouldn't, if you were trying to put moisturizer on your arm, you wouldn't just like drop a dollop of moisture on your arm and then let it stay there. So my advice is to throw away the applicator, put a small amount, maybe the size of like a large blueberry on the tip of your finger, and place it externally, which is often where people need the estrogen and have the symptoms anyways, and then into the vagina as far as they can reach. Usually we do this every night for 4 weeks and then decrease to 2 to 3 times a week. Most people have symptomatic relief in like 1 to 2 weeks, and certainly by the end of 4 weeks. For the ring, there are multiple types of vaginal rings. The E string is the type of ring that is just a local estrogen. And so that can be used. Some people, same thing as kind of what we've been saying with the menstrual hygiene products. There are some people who are like, great, something I can put in place and not have to think about for a while. Awesome. And there are some people like, you want me to put what, where? So I think it's just for personal preference. And then the pill, there are different dosing. Often we do 10 milligrams, but of placing the pill into the vagina. And sometimes that's the one that's most covered by insurance. So even though people often prefer the cream or the ointment or the ring, the pill sometimes is the thing that can be afforded. And then for systemic symptoms, I know we have a whole other section of this CME about menopause with my colleague, Dr. Adams, and she'll talk more about transdermal estrogen, I'm sure, but I think it's important to note here that we know that systemic estrogen also has an effect on the vagina. The vagina is part of the rest of the system. So there's transdermal estrogen, which we think of as a patch. We think that in studies that's been shown to have a lower VTE risk than an oral estrogen for hormone replacement therapy. And then a vaginal ring, the fem ring, is the one that provides systemic levels of estrogen, and then obviously an oral estrogen. So really thinking about those if the patient also has vasomotor symptoms. In someone who's 67, much less likely that they would also be having vasomotor symptoms if they're over 10 years from menopause. We think really hard about starting a new hormone, systemic hormone.
And then when do I have to give a progestin as well as the estrogen to protect the endometrium?
Yeah, so when we go back to these vaginal symptoms or systemic symptoms, vaginal estrogen or systemic estrogen, you only need a progestin if you're having a systemic estrogen, because the vaginal, even though the uterus is right next to the vagina, we don't think of vaginal estrogen as having an effect on the uterus or on the endometrial lining. But systemic estrogen causes the endometrial lining to grow and can lead to hyperplasia and carcinoma. So anyone with a uterus who is on systemic estrogen also needs some sort of progestin, like an IUD, a pill, something else to protect against hyperplasia. This is a table also showing some of the dosing. So you can see it's very small. I realize it's from the ACOG Practice Bulletin, Management of Menopausal Symptoms. You can also look that up. But there's systemic levels and then vaginal and local levels. So it goes through the different types of tablets, the ring, and creams and ointments. And you can see all the creams and ointments have evidence of benefit, and some have been FDA approved. And then also we'll talk more in the next slide about some non-hormonal options as well that have been studied.
Yes, so if my patient does not want to use or cannot use estrogen, then what are the options?
Yeah, so with that, there certainly are vaginal moisturizers, but really I wanted to zoom in on that table I showed where you can see there are estrogen agonist, antagonists, raloxifene and tamoxifen, which have not been shown to have benefit, and they're sometimes people on tamoxifen actually have worsening vaginal atrophy, but ospemifene has been shown to be helpful in reducing vulvovaginal atrophy and is safe to use with people who can't have estrogen, like people with breast cancer. So I think that's something to have in your pocket, especially for patients who really can't have estrogen. And then we talked a little bit about lubricants, not using KY. I don't want to be bashing KY, but I just want people to know there's lots more options out there. Certainly water-based lubricants are important for anyone using condoms, and we want to encourage that. But if people are not using condoms, then having a silicone or even an oil-based lubricant can be helpful with sexual activity or not. An oil-based lubricant is really any oil that can be placed in the mouth, can be placed in the vagina. Coconut oil, olive oil, mineral oil, all of those things. And then there are many silicone-based lubricants available that have just a different texture and also don't dry up as quickly, so have effects for longer. Vaginal moisturizers, you talked about Replens. There are some other ones out there. I think it's really important to make sure patients know the difference between a moisturizer and douching, because sometimes those are in the same section of a store. And then there have been lots of herbal remedies and soy products that have been studied, but none that have been shown to have clear evidence of benefit in all patients or in trials. And we talked about those.
And then when do I refer to you?
So I think when you think about vulvovaginal symptoms, really a specific visible lesion, if you're thinking someone might need a biopsy or might need an excision, that feels like a really good space for gynecology. Anyone who's non-responsive to treatment, even though most of the time it is a contact dermatitis or vulvovaginal atrophy, sometimes it can be more. And if we have to go down further layers of treatment or biopsy, I think that's really reasonable too. And then anyone who can't use estrogen, if you're not familiar with ospemifene, all those types of patients, we're happy to manage as well. And really, again, whenever, we're here for you.
All right. And finally, our last case, we have a 48-year-old with a vulvar lump. And on history, they have 2 weeks of a lump in the posterior aspect of their vaginal introitus. And over the last 2 days, it has become painful and warm to touch. And on an exam, as you can see in the photo here, they have a 3-centimeter soft, tender, unilateral fluctuant cyst at the posterior vaginal introitus. So what are some important questions I should be asking when a patient is presenting with a vulvar mass?
All right. So I think things that we think about are some aspects of the medical and surgical history that can make an abscess more likely. Certainly diabetes, any type of immunosuppression, any instrumentation to the vagina or rectum or in the groin area can increase the likelihood of an abscess, knowing that things drain downward towards gravity. Any type of rectal disease like Crohn's, ulcerative colitis could also put someone at higher risk of having some sort of fistula or abscess. So all of those things are really important to know about. And then any vulvovaginal practices or exposures, especially in this case, any new like hair removal, soap, any new sexual devices or anything that's being used on that area. And then any systemic symptoms, the same way you'd ask with anything where you were worried about an abscess or infection, fevers, chills, body aches, things like that. And then this is just a list of like common vulvar irritants. Certainly you can take a picture of this, but also just know that it's a long, long, long list and almost anything can be irritating to the vulva. So I always really flip this back to the patient and I'm like, is there anything that you think might be irritating your vulva? And almost everyone has some response actually, like people know. So this is some of the things to go through. And then I wanted to remind us of where the Bartholin or the greater vestibular glands are, because this is really important as we think about making a diagnosis or knowing that it is a Bartholin gland cyst. Is really the greater vestibular glands, as we call them now, are in this posterior aspect, kind of lateral in the vagina. If there is a bump or a lump somewhere anterior or more lateral within the labia, perirectally, those are definitely not Bartholin cysts. I get consults all the time for cysts as a Bartholin cyst. It must be like a code that our coder does too, but easier than like other types of cysts that are very, very out of the Bartholin space. So I think it's always just like a good reminder of if it's not there, it's a different kind of cyst.
And when I have a patient presenting with the Bartholin, if I confirmed it's in the Bartholin gland area, do I need to drain it or can I give antibiotics or what would you recommend?
Yeah, so I think actually very few people actually need antibiotics. A lot of people actually do really well with expectant or supportive management. We really recommend sitz baths up to sometimes 3 times a day, especially for smaller cysts. That can be really helpful. Incision and drainage has been shown to be helpful as well. And often we'll add a word catheter, especially if it's larger than 3 centimeters. For those that are less familiar with the word catheter, it's a small catheter that you fill with saline and then release about 1 milliliter of saline every week. And the idea is that it's holding open the cyst area so that it can't re-epithelialize over the cyst and actually has to heal from the back, so that if you just IND'd it and then left it, it might heal and reform, basically. We really only give antibiotics if it's recurrent, if there's a surrounding cellulitis, or if the patient is immunocompromised or pregnant. But if you are going to give antibiotics, these are the things that we commonly give. We commonly give Bactrim, metronidazole, doxycycline. Those are like the antibiotics of the vulvar region.
And when do I refer to you?
So I think a recurrent Bartholin cyst after treatment, certainly if you think someone is going to need a more involved incision and drainage, often recurrent Bartholin cysts get loculated. So there's actually like quite a bit of digging that happens. Sometimes it's important to be able to do that in the operating room for pain control. A deep or atypical location. So if you're like, wow, this is really not in the Bartholin cyst area, but it looks large and fluctuant the same way that I think of a Bartholin cyst, that's probably worth referring to. So just because we're thinking more about that anatomy all the time. And then anytime you're not comfortable, seriously, I can't stress that enough. We're always happy to help. And then these are kind of my takeaways. When in doubt, get a culture. It's really important for someone that you think may be at risk of a recurrent vaginitis to start building what it is, so they're not getting constant treatment for something that they don't even have. And that when they do have a recurrent vaginitis, we can kind of appropriately categorize them and get them the treatment they need. My public service announcement for vulvovaginal hygiene, I really put that into everyone's after visit summary. I think it is really important. Do an exam. I know all your patients aren't always undressed, but especially if someone's having vulvovaginal symptoms, really being able to locate them, see if there's a visible lesion is really important. Probiotics might not help, but probably aren't harmful. So it's something to have in your armory. And then we're here for you. Please feel free to consult gynecology anytime.
Thank you. Thank you for all of the helpful information today.
Yeah, thanks so much for having me.
Great. Thank you so much for that very helpful case presentation, Dr. Cahill and Dr. Jung. So I'll try to group these questions in the topics regarding boric acid vaginal suppository. I've seen that they're available OTC on Amazon. Do you recommend against these? And the second question is, for the boric acid suppository, are there any intercourse precautions?
Yeah, great question. We get lots of questions about boric acid. I think it's reasonable to order on Amazon, though I haven't personally evaluated that or checked that. But I think it would be reasonable to offer that to people. It can be really hard to get them counted. We do recommend avoiding intercourse near to having them. So I sometimes recommend for people to, if you're going to place them at night, skip intercourse for that evening, or if you're actively treating something, just because they can be really caustic. But I would say that's not the same thing. More important is that they don't get ingested orally. So making sure you're avoiding any oral vaginal contact with boric acid treatment.
I see. And is there a time frame for that precaution?
I tell people just the 24 hours, but I don't know that that's been studied of when it's out of the system, or if other people might have a thought on that too. I think we're probably extra conservative about that.
I see. Thank you. And then a lot of questions about lubricants. Do you have a preferred lubricant type for patients with recurrent vaginitis? Could you give an example of a water-based lubricant that you might recommend?
Yeah, I'm sure every gynecologist has their list of lubricants. I'm always cautious about talking about different brands because not affiliated with any brands, but there are, I think, having people try silicone or oil-based lubricants if they're not using condoms is just a different variety. Some people swear by coconut oil and sort of the more things that you would think about putting in your mouth. Some people really think those cause worse symptoms because we're learning so much about the individual vaginal microbiome. I don't think there's a one size fits all version. I have kind of a list that I give everyone of things that people have mentioned in the past that have worked for them, but I always say these do not work for everyone. Trying to find things with the least amount of preservatives, I think is really what I would say. And I think maybe some of my other colleagues, especially that are talking about sexual health, might have a true list they're going to give you.
Okay, great. And someone actually did ask about coconut oil-based lubricants. What are your thoughts? Or maybe what you already said about patient?
Yeah, I think patient preference and patient reaction to it. Not every vagina is going to react the same way to things. Some people think it's the best thing ever, and some people think it's super irritating. So I would say it depends. It's not dangerous to try.
Okay. And then a couple questions about topical estrogen. Do we need to worry about systemic absorption with topical estrogens? Is it okay to use a vaginal estrogen in patients with a history of breast cancer, for example?
Yeah, I get this question a lot. We do think there's very low systemic absorption. So I always think of this as like a really shared decision-making zone to talk about. Usually I talk directly with someone's oncologist about it as well as with the patient, just because it sort of depends on what else they're doing to reduce their risk. Sometimes people are really having huge quality of life challenges with vaginal irritation from other from their best breast cancer treatment. And so I think it really is a shared decision-making process. But we do think there is low to none systemic absorption of vaginal estrogen. But as we talked about, there are other options. So certainly wanting to exhaust the non-estrogen options first for someone with a history, especially of ER-positive breast cancer.
Yeah, and the same would go for DVT history as well. I have a patient who has history of DVT-PE as well as breast cancer. And so that was a good primary care patient that I coordinated with their oncologist and their hematologist, and all agreed to continue them on vaginal estrogen because it was helpful for them. And they really didn't feel like there was risk for an event based on the minimal systemic absorption.
Yeah, and I think we've often been like, but it's cancer versus vaginal symptoms, thinking those are like, how could we ever make those equivalent? But it's like daily disruption of someone's constant, ongoing daily disruption of someone's life, or an inability to access their entire sex life, versus maybe a possible low amount of systemic absorption, which maybe possibly would increase their risk of recurrence in someone who's already had, had full treatment for breast cancer. So I think like I would at least invite all of us on this webinar to really not be dismissive of vaginal symptoms as something that is so much less important than any risk of cancer. And I think my colleagues will talk about that in terms of HRT and things too. We take this really seriously.
Thank you for both sharing your guys' experience. Another interesting question, is there any evidence, or what are your thoughts on intravaginal topical plain yogurt for recurrent candidal vaginitis in patients who have really failed topical antifungals, oral fluconazole, etc.?
Yeah, I think the yogurt really is getting at the live cultures and probiotics. So I think some of the research into probiotic use for both prevention and treatment can be somewhat extrapolated to the use of yogurt. That's what you're really trying to place, is really the probiotic live cultures. So I think I'd use that same framework of it may help, but it's not something that we would start with. Absolutely. And the same thing, like it may be something that someone is really much more comfortable doing than boric acid, for example. And so having some shared decision-making around that. But I think it can be in your repertoire, but knowing that all it is the probiotic component of the yogurt.
Interesting. Are there any specific probiotics you would recommend for recurrent BV? For example, in the GI literature, only certain brands help with IBS.
Yeah, I think that's tricky because those studies are really hard to separate out from people trying to create specific products. And I think, like many things in women's health, and certainly things in women's health in older women, that there's a lot of sort of predatory practices because there's not specific data on like head-to-head comparisons of things. So there's no specific probiotic, the different types of lactobacillus species, basically. So that would be, but as you saw in some of our slides, like we're learning more and more finally about the vaginal microbiome, and realizing that everyone's vaginal microbiome is probably a little bit different. But the lactobacillus species are certainly the ones to emphasize for the vagina.
Got it. Thank you. And lastly, patients often ask if there's anything their partner can do or take if they're getting recurrent BV or recurrent yeast infections. What are your thoughts there?
Yeah, great question. I think this is a great area of study. I think it seems like reasonable to think about probiotics or diet changes or things like that. We certainly know that there's probably more partner dependent components of bacterial vaginosis. So I think I'm so happy that people are starting to think about that. I think years ago, we would have never thought to ask partners to adjust anything for vaginal symptoms. And so I think there's no data that I know of that suggests specific things, but I think it's really reasonable to think about that as an exposure, the same way we think about like clothing or soaps and things like that. So thinking like playing with that and experimenting to see, are there diet changes? Do probiotics help? Do different types of lubricants, condoms that the partner is using change things too?
Okay.